name is Brian Williams. I'm Legislative Director at the National Center for Policy Analysis. Welcome to this briefing today. We thought we'd put on a briefing for y'all to talk about some innovative health solutions that are happening out there. Entrepreneurs that use the power of the free market to solve people's health problems. And this is what we're going to be talking about today. I hope everybody got a packet. If you didn't, there's some more out on the registration table. Included in the packet is the bios for all the speakers. So I'm not going to spend a lot of time introducing. I'm just going to quickly cut to the chase. So to your left, at the far left is Ralph Weber. He is the Chief Executive Officer of MediBid, and he's going to tell you a little bit about some of the things he's doing. To his left is Larry Wedekind. I always trip on that. I practice that in the mirror. Larry Wedekind, and he is the Chief Executive Officer at Integranet Health. And again, he's going to tell you about some of the cool things he's doing. Seated next to him is John Desser. He's Vice President of Government Affairs over at eHealth. And you guys used to be eHealth Insurance, and we changed this to eHealth.
Whatever, however you find us quicker on the internet.
And then to wrap everything up is our own Devon Herrick. He's a senior fellow over at National Center for Policy Analysis and is one of our health experts, and he'll kind of wrap everything up. So without further ado, we'll start with Ralph and just move our way down.
Thanks, Brian, for having me, and Devon, and thank you everybody for being here. I want to talk to you today about some of the problems with our existing system and some of the solutions that we're bringing to the market. I'll start by talking a little bit about MediBid, if we can go ahead, and of course you've got these slides in here. Basically what MediBid is a competitive marketplace which allows doctors and hospitals from across the U.S. and overseas to show their services, to present their quality outcomes, and talk a little bit about their education, training, and experience, so that when you're searching for a doctor or facility, you have that information. What is sorely lacking in the current landscape is transparency. Transparency in healthcare is sorely lacking in terms of pricing and in terms of quality. Most people look at a directory and all they can see is whether my doctor is in network or out of network. So we provide that showcase. We have generally three kinds of patients on MediBid. The first kind are uninsured people. People, that may be self-insured. There are some faith-based cost-sharing groups that are exempt under the ACA from the individual mandate, so those kinds of people will use MediBid to get competitive pricing. People with high deductible health plans that are trying to shop around, that want to see the quality of the provider and the price and save some money. And the third kind, and by far the largest, are employer health plans, self-funded health plans. When an employer self-funds, and 76% of corporations self-fund their health benefits, they traditionally use a PPO network to source care. And we're going to talk about that in a few minutes. MediBid provides an option, an alternative. It can replace a network or it can enhance a network. The patient goes online and they see the kind of care they need. They make a medical request. And this request is sent not only across the U.S. but overseas. Doctors respond with a competitive bid. The doctors benefit because they set their own prices rather than the price that's set by their PPO network. So they get to set their price, and they will explain why they're asking that price, which might be higher or lower than their competitors. The patients benefit from a savings of up to 80% versus bill charges and about 50% versus insurance discounted rates. The problem in the status quo, in your regular, health plans, whether they're one of the big insurance companies or even many of the self-funded employers, one of the problems that's inherent is a huge range of allowable, for any given procedure. And I've got some slides that in a few minutes that we'll go over. They sometimes vary by 1,000% or more. Within any given network, for example, in San Francisco, the price of a colonoscopy ranges from $800 to $8,000. And the difference usually in that range is just the facility where it's done. The doctor will very frequently get paid the exact same amount. It's just the facility, which usually does not affect the quality. Most people today under health plans, now the ACA of course limits the out-of-pocket maximum to $6,600. Most procedures will exceed that deductible. An employee, once they've exceeded their deductible, transparency alone, they don't really even care about. There are some people in the market that are providing transparency, which is really good. It's very, very necessary. But once an employee's exceeded their deductible, especially if they're paying a portion of the premium for the health plan, they just don't care. And some mistakenly think that the $95,000 guy is better than the $20,000 guy, whereas often they're not. When businesses buy things or government agencies buy things, they go to bid. When they're buying a new computer system, a sprinkler system, phone system, they'll usually have a few different vendors bid, okay? That's the competitive marketplace. That is not done in healthcare. Although employers will sometimes check with a few different insurance carriers, once they do that, the insurance carrier uses a system which is based on price fixing, where there's a build rate and then there's a discount off of the build rate. And a lot of the insurance companies, they compete by saying, well, our discounts are greater. Our discounts are 52, theirs are only 49, okay? But discount from what? Discount from an artificial build rate to the allowable, and then after the allowable, there's even a further reduction before the physician is paid. Think about how Travelocity changed the way we buy airfare, okay? Before Travelocity, there were rack rates with 3 or 4 simple rules. You'd call the travel agent and they'd say, well, are you booking 21 days in advance? Are you staying a Saturday night? Are you under 12 or over 65? Or are you on standby and 2 hours before flight time? Those things dictated the amount of discount. Now with Travelocity, it's real-time dynamic pricing, and it's based on occupancy rate. Okay, how many seats are sold in the airplane? How many rooms are booked in the hotel? That dictates the price, and that's dynamic. And that's what we're bringing to medical care that the status quo doesn't. Medical care within any given health plan, medical care constitutes 80 to 85% of the healthcare spending, and the rest is overhead, administration, profit, and taxes. Okay, and this is of course mandated under the ACA. But under a typical health plan, who is the consumer? Who is the consumer? Who's the customer? It's really the health plan. It's not the employee that's covered, okay? Yes, you can make a decision with a generic drug versus a name brand, so maybe you have a little bit of a lower copay. So that's a very, very small little bit of consumerism, but today's millennials demand a whole lot more. Millennials are not going to be satisfied with the status quo. They want to research, and many of you here are in that category. You want to research. You want to pull out your note or your tablet and you want to research and you want to find out more information. You're not going to be satisfied with just taking somebody that's in network. The old model, in 1973, the HMO Act passed and managed care was born. Under that model, the doctor was the gatekeeper, and denial of care was how costs were controlled. And then, of course, the PPO morphed from that, preferred provider organizations, where they are, pre-negotiated discounts. But they still have this, this crazy build amount and then this discount, and it's just a huge waste of resources. The only sustainable solution is to make the patient the consumer. When the patient is the consumer and is asking the questions, other than to question, am I covered? They need to go beyond that. So when the patient is consumer and they have the tools to give them not only transparency, but the tools to make good decisions, then that's when the costs will come down. Now I've got a few graphs here, and I'm not going to spend a great deal of time on them, but the first one, I'll talk about this one, then we'll flip through the other one. In Oklahoma City, now the first two lines from the left, the first two lines represent a national insurance company network. That is the range of price from $16,949 to over $95,000 for a knee replacement. That is the range of allowable. When an employee goes online, actually under the status quo, they'll go online to see which doctor's in network, but you have no idea if you're going to the $16,000 guy, the $95,000. And the $95,000 one is not necessarily a better outcome, There are a lot of people that say you need to pay more to get more. In healthcare, the exact opposite is often true. A doctor will get paid by the procedure code, okay? And it doesn't matter if it takes them half an hour or 3 hours to do the procedure. Hospital and anesthesiologists, however, often get paid by time. So if you have a skilled surgeon that is in and out in 45 minutes, gets the job done, minimal risk of exposure or minimal blood loss, because they do a lot of these procedures, they only use 45 minutes of OR time. An inexperienced surgeon might use 3 hours because they only do 3 of these procedures a year. The hospital will bill a lot more. So often billing more gets you less. The next two in the middle, let's go back. Actually, it doesn't matter which we're on. The next two in the middle represent, the blue one is the Medicare price, okay? And then the next one is Medicare plus 30%. Now, Medicare and Medicaid make up more than half of healthcare spending in the US. So if you ask yourself, what is a benchmark price? Medicare, Medicaid prices are probably decent benchmarks. No facility is forced to accept a Medicare contract. Some of them will complain that they get underpaid. Well, if they feel they're being underpaid, they shouldn't have signed the contract. The last two lines that you'll see, the red one is the MediBid low price, and on the knee replacement it's $7,500, and then the last one is the MediBid average price, and for knee replacements $13,000. Okay, so the market will return these kinds of prices, and with the employee given incentive with a properly designed health plan, they can be smart shoppers. So we'll jump past these graphs. We'll stop just for a second on the multi-market knee replacement. That shows in different markets, and it's a little bit small, but you can see in every market, in the PPO network, there is huge spiky risk. And when an employer is exposed to this spiky risk, that's what increases the cost. We've carved that out. We've carved those spikes out of health plans. And it works within the ACA. Transparency, I spoke about that a little bit earlier. There are some innovative companies providing transparency. Transparency is important in a competitive marketplace, not only of price, but of quality. However, mandated transparency without the market forces to really drive competition is like a mirror without a comb. Just like legislative happiness would create plastic smiles, transparency without competition just gives you a rear view mirror to see what you could have or should have or might have paid. Okay? It doesn't actually drive down prices. So how can the market help? As we've said, transparency is essential. It really is, but it's not enough. PPOs are opaque and prevent competition, and we've had some YouTube clips of people talking about lack of transparency and things like that. That exists in health plans today. It's lack of transparency and that being hidden from the patient. The ignorance, lack of knowledge on behalf of the patient is what has allowed this to happen and allowed it to get worse and worse and worse over the years. They operate much like a monopoly, insurance networks, okay? There's a gag order where often the employer can't ask the provider what they actually got paid for the procedure. So it's a monopolized system. And they're based on static pricing, as I said earlier. In order to really get effective, and in Houston, there are some nonprofit hospitals that are running at a 20% occupancy rate. 20% of their beds are filled, but because they're nonprofit, they have to spend the money that year, so they get close to the end of the year and they've got a whole bunch of profit, and they say, what are we gonna do? Let's build another hospital. So they're building more hospitals when they're only running at 20%. Now they've got two running at 10%. So utilizing the resources, doing an MRI after 8 p.m., things like that, okay? Those are market forces, and the market forces can be harnessed. So the solution, what is the solution? Well, we know it's not rationing, okay? Rationing doesn't work, it just creates waiting lines. We know the solution is not opacity. We know that it's not keeping patients in the dark. We know that the gatekeeper model doesn't work either. And even utilization review, it's important, but that doesn't control the cost. Only the market can control the cost. How does the market control the cost? By making the patient the consumer. Once the patient is the consumer and involved in their own health care, and they have the tools and they have the incentives, that's what's going to result in sustainable cost reductions. Dynamic market pricing, as I spoke about a couple of minutes ago, like Travelocity, when you need a knee, when you're booking a room on hotels.com, let me use that as an example. If you're flying in somewhere, you arrive at 11 p.m., you leave the next day at 7 a.m., it's just a stopover, what do you want? You want something close to the airport, that has a shuttle, that has breakfast. That's pretty much it. That's all you need. If you're arriving at noon and leaving the next day at 3 p.m., well, you want a fitness center, you want a pool, you want a restaurant, you want different things, okay? And it's the same in healthcare, okay? Look at LASIK surgery. LASIK surgery is not generally covered under health plans, so the market has been allowed to prosper. When people look for LASIK surgery, they look at all the different things that they want, okay? Market-based supply and demand is driven, and it drives resource optimization. So competitive bidding through MediBid has driven averages that are 51% lower than insurance discounted rates in many cases. That's just by simple competition, just by giving people the incentives and the transparency to make those choices. And I'll give you an example. A client in Seattle, telecom company, I helped them with redesign their health plan. We were able to reduce their deductible from $3,000 annually to $100 monthly. Okay, from $3,000 annual to $100 monthly, and it reduced their cost by about $800,000 because it uses dynamic pricing. Okay, and it enlightens the consumer, it enlightens the employee. State of Florida, if they employed, and I testified in Florida about 12 and a half months ago on medical bidding. They wrote a bill which passed the House last year that would allow their 171,000 state employees to utilize medical bidding in their state health plan. That could save them $600 million in the first year, and by 2018, it'll still reduce their spending versus today by $500 million a year. So those are pretty substantial savings. If all employers just made one change to their health plan, going to dynamic pricing rather than static, it could save the healthcare system as a whole $600 billion a year. Billion. A small employer with 300 employees could save $1 million a year. Okay, just by going to static pricing, medical bidding, transparency and competition. Mid-sized employer with 10,000 can save $30 million a year. The average state can save $100 million a year. Okay, and it works within the status quo right now. Just the health plans are redesigned. I'm within my time limit, and it looks like we might have some time later for questions. My contact information's on the back. If anybody would like to contact me, I'd be happy to speak to you further.
Hi, I'm Larry Wedekind. I am the CEO and founder of Integranet, and we call it Integranet Health, or Integranet for short. We were founded in 1996. We have been serving health plans for that entire time. We serve Medicaid, Medicare, the dual eligibles, which are Medicare and Medicaid, mainly disabled, economically and physically disabled people of any age, adults, and of course Medicare. We have been serving health plans in the Medicare Advantage program for over 10 years. Integranet is different than most independent practice associations in that we also serve 501As, which are physician organizations that are controlled by hospitals, but we prefer independent physicians. So I want to say at the outset as a background to my talk that physicians are not equal in how they respond to the consumer marketplace. Independent physicians who run their own practices, these are primary care and specialist physicians, what I would call non-hospital-based physicians. They are motivated by economics to run a good business. if they don't run their business well, which means providing good access to patients when they want them, which means having staff that is caring, compassionate, and efficient so that they can see everyone who wants to see them, opening up late during the week and opening up on Saturdays and or Sundays. You know, these doctors that do this well, we call medical homes. When they do it really well, we call them patient-centered medical homes. And I know you've all heard this, but I'm going to go through some of this theory just to make sure that you follow what I'm going to say here in just a minute. So what Integranet does is we establish patient-centered medical homes. We surround these medical homes with care coordination. Okay? We coordinate care. I'm going to talk about what that really means in a minute. But care coordination is really important. A lot of HMOs, PPOs, IPAs, physician groups, they will tell you that they provide care management. And they'll also talk about care coordination. The truth is, doctors provide care management. When you need something, you don't go to an ACO or an IPA or an HMO, you go to a doctor, right? And hopefully you don't go to the ER unless it's absolutely necessary. You go to a doctor. But you have to establish a relationship with a doctor first, typically. Otherwise, you go to an urgent care center. And you may or may not get a great doctor when you go to an urgent care center. Trust me, I know. So establishing a patient-centered medical home is the first step in saving money system-wide, in saving money for the patient in their out-of-pocket expense, and saving money for the insurance companies, right? It's the first step toward a win-win-win solution in healthcare. The second step is making sure that every patient's care is coordinated across the continuum of providers. So you may have a primary care physician as your medical home, and we strongly urge that at Integranet. But if you don't have a good set of specialists that the medical home is connected to, then you're going to lose. You're going to end up in an ER and probably in a hospital bed, because what does a hospital administrator think of in the morning when they wake up and in the evening when they go to bed? What do they think of? How do I fill my beds? I was a hospital administrator for 25 years. Small and very large hospitals and regions. Even as a regional director, no longer in charge of a hospital, all I thought about, I promise you, was how to fill the empty beds. And there are always empty beds. It's like a hotel. Okay? So when policymakers are looking at establishing policy, like the Affordable Care Act as an example, they should remember that hospitals are hotels, and they don't make it unless the beds are full. Right? So that has to be paramount and in the forefront of policymaking. You really don't want hospitals in charge of accountable care organizations, right? Everyone knows what an ACO is, I hope, in this room. So why would you put hospitals in charge of accountable care organizations when their motivation is to fill the beds? Why would you do that? CMS did it in the PPACA. Makes no sense at all. And this fox guarding the hen house philosophy is continuing, even in the proposed new final rules. So what Integranet does is we establish independent medical homes, independent from the hospital and the health plans. And we empower these medical homes. We empower them with care coordination primarily, also case management, utilization management, all those things. So what does care coordination really mean? Next slide, please. It means the right care at the right time and in the right setting. 3 concepts only. This is what care coordination does. This is what it accomplishes. It makes sure that you, the patient, have the right care. What does that mean? It means that you receive the care that you need at the right time, not the care that the provider thinks you need to have at the right time. Who's in charge of medical decision making? Right now it's the provider. It is. It should be the consumer, like Ralph just said. It should be the consumer, but it really is not most of the time. Even when you go to MediBid and you get the best pricing, you're still not really in charge of your care. The doctor is. No one can do anything in a hospital or an imaging center or a surgery center anywhere unless you're a doctor. Now that's the way it should be. They're the ones trained to do that. But the consumer needs to interact with a medical home that understands everything about that consumer. Okay, not a medical home that is only there, when you've got a problem. We call it a chief complaint. So you go to the doctor because you've got the flu. Well, what the doctor should know already when you go in for the flu or pneumonia or whatever it might be, that doctor should already know your history, your disease history, your injury history, your medication history. That doctor should understand where you are at in your life cycle, right? Are you 55 years old and you're starting to have diverticulosis, right? Or CHF or anything? That doctor should really understand who you are and where you are in your life cycle and what you need, what we call holistic health care or wellness, those sort of things. But the way we're set up today in America, it's very episodic, right? So Integranet's job is to move primarily our PCPs from episodic care to episodic plus wellness, right? Which includes preventive care and which includes understanding the history, the lifestyle habits, all of those things that are so important to each one of us as a consumer and as a patient. So care coordination means also that it's in the right setting. So what is the most dangerous setting for healthcare in America? Hospitals, thank you. Yeah, if you don't know that, then you need to really understand that. I will not go to an ER for any reason other than paralysis or coma. I'm just telling you. And I've had some issues, right? So I'm almost 60. So when you're almost 60, you have issues, depending on your behavior and your lifestyle. So I'm healthier now than I was when I was 30, but it's because I've changed my behavior, mainly eating habits. So, but my medical home has helped me do that, right? I'm lucky enough to have the best medical home because I'm in the healthcare business. So I'm very lucky. So, but Integranet established this for everyone, regardless of the ability to pay, regardless of what kind of plan you have, whether you're Medicaid, Medicare, whatever. Our physicians sign care coordination agreements with us, and they have to provide this kind of care: episodic, holistic, and wellness preventive care. And this is why Integranet has the record that we have. So go back to the accomplishment slide, if you don't mind, Brian. So what we've done is we formed an ACO in July 2012. We were an early adopter in the ACO business. Now you're going to find out from me shortly that the ACO law is very perverse and very difficult to operate within in the private sector. But we went ahead and did it because we believe in the theory behind it. Okay? We believe in the theory behind it. So we were the #1 performing ACO in the country between 2012 and 2013. We saved more money during that 18-month period compared to our base year, 2011. They took 2009, 2010, and 2011 as the base period, a 3-year period, and they weighted most of the costs in 2011, 2020, I think, and 60, right? So that base year was very relevant. So all the members that we were assigned in the ACO in 2012, July of 2012, those members' costs as a group were compared to our cost in our first year, 12 and 13. We saved almost 10%, actually, I'm sorry, we saved more than 10% the first 12 months. And they actually took money away from us on the savings because they have a maximum of 10%, which again is kind of perverse, really, you know. So, but that's what they did. So we did that on a per member per month basis. That's apples and apples. Some ACOs have more members than other ACOs, so the only way to compare them is per member per month savings. We did more than anybody else. Why? Because we've got a 10-year history of successful risk-based Medicare Advantage partnerships. We were already an accountable care organization in the true sense of the word. Okay? So our Medicare beneficiaries, we actually improved their health. And by improving their health, we save money. Why? Primarily because they don't go to the ER. They go to a doctor's office. Our members, we actually encourage them, when they have chronic diseases especially, to go every month. When we have diabetics that are out of control, we tell them to go every week. And there's no out-of-pocket for that because they're going to a PCP under a Medicare Advantage plan. So we're not costing them any money. It's a beautiful system. Medicare Advantage system really is the model for our country. However, the government gets involved and they want to control things, and so then everything goes, wrong. So let's go to the major challenges slide. So the major challenges with the Affordable Care Act, which I support, by the way, I support the Affordable Care Act, but not in its current form. I support the theory behind it, the philosophy behind it. The philosophy basically is the private sector using network management and care coordination and case management should lower costs overall by creating healthier populations. You've heard of the triple aim: improving access, improving the health of the population you serve, and lowering the cost as a result. So the triple aim is good. It's philosophically correct. The devil's in the details, right? So we need to change the details of the Affordable Care Act. I'm going to talk about that right now. So what the issues are structural. So structural issue number one, you heard Ralph talk about, I made a note on this, I thought it was so good. He talked about pricing, right? So the main structural issue in the way ACOs are set up now is the consumer is completely ignored in the ACO. Beneficiary assignment, beneficiary meaning the Medicare patients, it's done retrospectively. And we call it attribution, the attribution of beneficiaries to providers. Attribution is retrospective at best, very untimely, which means that the ACO and the PCPs have no idea who their members are until the end of the plan year. So how are you supposed to manage and coordinate the care for beneficiaries when you don't know who they are? That's the way the law is now. I'm telling you, as the number one performing ACO in the country, we call our ACO Physicians ACO, PACO. PACO doesn't know who its members are until the end of the year. Furthermore, we don't know what our members spend until the end of the year, each plan year. It's ridiculous. So what does that force us to do? So that's why I say the consumer is ignored. Furthermore, I'm not sure if it's on this slide. Go to the next slide. So what that means is you have beneficiary confusion. These beneficiaries get a call from the ACO and from their assigned PCP. CMS does the assigning in the ACO business. So on Medicare Advantage, the ACOs are patterned after Medicare Advantage. In Medicare Advantage, you, the beneficiary, choose your health plan, your ACO, if you will, and you choose your doctor. You choose your PCP. CMS decided that they know better than you do. So they assign you, the beneficiary, to a PCP, and it's often not the one that you want. and it's often a specialist, it's not even a medical home, true, and they assign you to an ACO. And then all of a sudden you get a call and a letter from the ACO, and they tell you that you've been with the ACO and this PCP since this date, 6 to 9 months ago. And then they have to ask you if you want to be engaged. And you have the right to say no. And many do. And so here you are, an ACO, right? You're spending tons of money, right? Why? Because what we're forced to do under this law is we're forced to take all non-Medicare Advantage patients, what we call all non-managed Medicare beneficiaries that have been assigned to a PCP, and we're forced to take care of all of them. And now you're saying to yourself, well, I don't understand. Doesn't CMS assign all non-managed patients to an ACO? No. When I went into the business, I thought they would, but no. Basically, we have received, and all ACOs have received, about 40% of the non-managed Medicare beneficiaries in our practices. And then that 40% changes 50% before the end of the year. So the beneficiaries that we start with, and we don't find out for 6 months, but when we find out who they are, 3 to 6 months later, 50% of them are gone. And we have new ones. Who are they? They're the other 60% that weren't assigned in the beginning. Well, I'm sorry, they're a portion of the 60%. Do you see how perverse this is? This is the way the law is. And CMS is expecting us in the private sector to somehow create a win for the taxpayers. I mean, so the consumers are not involved. They are incredibly, consumers, the beneficiaries, incredibly confused. And we're unable to manage them unless we just decide to manage the whole population. So, next slide. So what happens then is, so if we were being paid by CMS for all the care coordination, the case management, the network management of our doctors, then, that might be okay, because at least we're paid for the ones eventually, right? And we can use that payment to manage all the patients that are unmanaged. And CMS doesn't hesitate to tell us at our conferences that they expect us to manage all the beneficiaries that are not in Medicare Advantage plans. Is that equitable? Especially when they're not paying us? There's no payment. The only way we can get paid for all the nurses and the doctors and the provider relation representatives and everybody else, the coders, everybody Integranet staffs for the ACO, we have to get paid out of our portion of shared savings. But if we don't actually accomplish savings from the previous year, we get nothing. So CMS, the federal government, is expecting the private sector to take care of these Medicare patients. Now, these are people who are 65 years and older, or if they're younger, they're disabled. These are sick people. These are not commercial populations, okay? So they're expecting us to take care of these very sick people who are getting older every year, by the way, and getting sicker without our intervention. And they're expecting us to do it for free. And we're supposed to hope that we can save money. So I'm going to ask another question. Has there been a year since Medicare started in 1965, has there been a single year where Medicare costs have gone down on a per member per month basis? No. They always go up. So we're supposed to stop the rate of increase with no money to do it with, by the way, and we're expected to actually lower the costs, not just lower the rate of increase. We're supposed to lower the costs. And if we lower the costs without any help from the government, then we can get 50% of the shared savings. Oh, but wait. There's a minimum shared savings that's expected in the Affordable Care Act of 2 to 3.9%. So let's say that you saved 1% on 10,000 members. 50% of 1% on 10,000 members is not quite enough to pay your costs, but at least it would pay some of the costs. But if you save less than 2 to 3.9%, depending on your size, you get nothing, because that's the minimum savings rate, right? So, and then if you exceed 10%, you get nothing beyond the max. So that's how perverse the law is. So and there are many other perversities, but I've run out of time. So let's go to the outcome slide. I encourage you to, it's the reforms needed slide. So I encourage you to just read the other structural deficiencies. I've covered the ones that are really grievous. We also have quality thresholds, 33 of them, that we have to attain, and the quality thresholds are built off 5-star Medicare Advantage methodology. I don't believe a single Medicare Advantage plan in the U.S. achieved 5-star last year. And yet, CMS is requiring us to be 5-star in our first operational year on all of these quality indicators. Does that seem fair? Does it seem even possible? It's not possible. And I promise you there won't be a single ACO in 2014 or 2015 that can attain the 90% threshold compliance on all 33 measures. I won't be able to do it. And I'm spending gobs of money to do it because I want to be the first to do it, but I'm sure I can't. And I didn't in 2014. So even an experienced independent risk-sharing independent practice association like mine can't do it, right? And we are hemorrhaging trying to. And so we will not even get our 50% of shared savings because we can't do it. But this is what the government expects. It's crazy, okay? And we all get pretty cynical. So what are the reforms needed? First of all, we've got to assign beneficiaries to the ACO and the providers prospectively before the plan year starts. And CMS must not add or delete from that membership. Secondly, CMS has got to notify the beneficiaries of the assignment. Third, CMS should assign all unmanaged Medicare beneficiaries in a practice to the ACO, not just part of them, and they absolutely cannot change it. Fourth, they've got to pay us an administrative fee. That's what happens in Medicare Advantage. The health plans pay us, typically about $18 PMPM, so that we can deliver the services in a high-quality way. CMS needs to do the same thing, or they need to get out of the business. We need to restructure the shared savings model so it's more equitable, so that ACOs can actually get a reward for decreasing the rate of increase, not just saving money. And certainly the minimum thresholds need to go away, period, right? That would make sense. We need to restructure the quality threshold so that it's actually attainable. We need to, CMS provides horrible technical support. I mean, the website's down half the time, as you can imagine. It's really difficult to work with them. And they don't provide us timely information on claims. All of that needs to change. And they also need to incentivize the beneficiaries to get preventive health services and wellness services. That's easily done. CMS won't do it, but it needs to be done. So I hope that you will go back, talk to your congressman and your sphere of influence, and share this with them. It could be a great law, and it could really help America and save money. Thank you for your attention.
Good afternoon, everybody. I'm John Desser. I'm with eHealth, and I'm going to run through this kind of crisply to leave some questions, time for questions at the end. So let's just go to the first slide. You heard a little bit from my colleagues about the need for injecting more consumerism into healthcare and for integrating and coordinating care. I'm going to talk about how to just access traditional health insurance. And so what was the problem we were trying to solve? Well, my founder, who's a good friend of mine, got very sick when he was in grad school, didn't go to the doctor because he didn't have any money, and he almost died. And that could have been prevented. Later in life, after he graduated from Wharton and Stanford and all the rest of that, he was in the middle of the 90s internet boom, and he started asking himself the question, is the internet capable of doing anything to prevent what happened to me when I was in grad school? And the answer to that is actually yes. We could use the power of the internet to display all of your health insurance options where you live and allow people to shop and compare and actually apply and enroll all using the internet, doing it all online. So that's what we started to do. Buying health insurance typically previously had been viewed as a daunting task, kind of intimidating. There are all these acronyms you didn't understand. We can explain all of that online. We have videos that explain it, etc. The internet is a perfect application to help people figure out their health insurance options. What used to take weeks or even months, now we can do in minutes. We sold the very first health insurance policy over the internet with a digital signature in 1999. And at that time, our biggest expense as a company was FedEx. Why? because after someone used the internet to apply for and enroll in a health insurance plan, we had to print the application and then FedEx it to the carrier because they had no technology to integrate with. That problem has since been solved, but that was, at the time, our biggest expense. Now it's engineering. So a quick overview of our company as it stands now. We're publicly traded on NASDAQ. We have 15 years of online health insurance marketplace experience in all 50 states and DC, 180 different insurance companies with 13,000 different products you'll find at our site at eHealth.com. More than 20 million people come to our site each year, and we've covered more than 4 million people. We've been rated the best health insurance website by Kiplinger's for 5 years straight. In addition to the website, we have more than 400 licensed call center agents, and I emphasize licensed, because when you call the healthcare.gov's telephone support, you're not talking to an insurance agent. You're talking to a person managing a call center. Our agents are actually certified and allowed by law to give you advice about the insurance you purchase. Theirs are not. We have that phone support available 363 days a year. I think we take off Thanksgiving and Christmas. And we're available 24/7 via chat. All right. This is a picture of our homepage. Check it out, eHealth.com. Now, next slide. Enter the government. The Affordable Care Act and its impacts on certain private exchanges. The good, the bad, and the ugly. I'm going to mix my movie references here, and I'm going to ask everybody in the room, raise your hand if you've ever seen the movie The Princess Bride. Most of you. There are two great things, lessons learned from Princess Bride, and I'm going to add a third. The first one was, don't ever get in a ground war in Asia. Do you remember that? Second was, don't go up against a Sicilian when death is on the line. And the third one I'd like to add is, never let the government enter the e-commerce space, especially when health insurance is on the line. Next slide. So you might say that imitation is the highest form of flattery, and we found out that's partly true and partly not so true. As far as our feeling about the Affordable Care Act, we've always thought people should be provided extra help financially if they can't afford private health insurance. We've supported that. There also needed to be a better solution for people who are hard to insure, like high-risk pools. The ACA went with guaranteed issue. That's a different way to skin the cat. And what we found with the ACA and the government getting into our business, essentially, is they started pouring ridiculous sums of money into advertising. When we pay for advertising, there has to be a return on investment. We can't take our resources from our investors and squander it on advertising and have no relation to what we're going to earn back with that advertising. Guess what? The government doesn't have that restriction. Because it's taxpayer money, all they have to do is print more when they want to. And it doesn't matter how many people sign up. They can advertise hundreds, and they did, hundreds of millions of dollars for the initial open enrollment period last year. That had a side benefit to us because people did go online and look, and oftentimes they'd find us. By the way, we used to be the #1 result in Google search, both organic and non-organic, and now we're not because we're competing against this 900-pound behemoth called the federal government. And then we, of course, tried to help them a little bit in the initial days, 0 glitches, 0 problems in 62 days, put up a health plan finder. Then they said, okay, we don't want to use the private sector anymore. We want to build our own website. We saw how that went. So for us, the first year was actually good because we saw a significant increase in application growth simply because of the droves of people going online due to the advertising that healthcare.gov did. Now let's look at the good, bad, and the ugly. Now that was the good. Let's look at the bad. The very first draft of the Affordable Care Act actually was going to put our company out of business. It said that if you have the gall to buy health insurance outside of a single national-run government exchange out of Washington, D.C., Mr. Waxman was going to impose a 100% surtax on you for the price of that policy. That would have killed us. So it was clear that their initial goal was maybe actually to kill us and just have the government run health insurance marketplaces for the whole country. We fought that with everything we knew how. and that 100% surtax was removed. We worked in the Senate to make it clear that people who qualify for tax credits, as well as people who don't, could come to us and also buy a qualified health plan. And that amendment was successful. And you might remember reading in Roll Call or in the Washington Post that at the very last minute, before the bill went to the floor, it went to Senator Reed's office, where they just tinkered with it a little, made a few changes. They changed a may to a shall to a may, and now it was just permissive to states to allow people to come to us, not mandatory. Also, we had some other delays in getting started and actually doing some testing. The technology that CMS deployed for us to work with was really, really bad, and we had to come up with some quick fixes. All right, next slide. The ugly. If you didn't think that was bad enough, imagine this. An estimated 2.1 to 3.5 billion with a B dollars to set up the federal exchange. How much taxpayer money did we use to cover the 4 million people we've covered? Zero. Not any. We did build this, actually. In this case, the government built it and built it pretty poorly and spending an enormous sum of money. These estimates, by the way, come from a report done by Bloomberg.gov. Another $3.9 billion to set up 14 state exchanges, 4 of which practically didn't work, and 2 of which were completely scrapped. The launch of healthcare.gov was, I think, well known and not so great. Here we are 2 years into this, and none of the 14 state exchanges have deployed any resources to allow us to help tax credit eligible people sign up for health insurance. And I emphasize that because there is a provision in the law where they said, we're not going to force everybody to go to an exchange. We're only going to force the people who get money from the government to use an exchange. And that's a terrible flaw in this law, in my opinion. Okay. How do we fix these problems? It's quite simple. First of all, one option would be just get rid of the government exchanges. Why do we need them? All right, what's the government's role in healthcare? What's a proper role? It's not to own the system, it's to make the system fair. All right, so we don't want people dying in the streets of hunger, so we give people food stamps so they can have something to eat. We don't want them using those food stamps for tobacco and alcohol, so we say you can only buy real food with these food stamps. But we don't build thousands of grocery stores around the country in order to let people with these food stamps get their food. And essentially in healthcare, that's what they did. They spent billions of dollars creating a competitor to a marketplace that already existed. And not just us. There's 3 or 4 other companies now who do this on a national scale. So one thing you could do is just get rid of the government exchanges in the first place and let anybody who's tax credit eligible or anybody else enroll through any of the national exchanges that already exist or through their broker or from the carrier directly. No need for these government exchanges. The government's role here, in my opinion, ought to be simply to tell you if you are actually eligible based on your citizenship status. They have that data, we don't. And to tell you how much of a tax credit you actually qualify for. That's an appropriate role for the government. But to be in the e-commerce space, I would argue, is not. Second option would be to get rid of the state exchanges and allow the federal exchange to continue to exist as sort of a fallback option for consumers. And let's eliminate this ridiculous spending of money for advertising for the government exchange. A third option would be to get rid of the federal exchange and just allow states who really feel strongly that they need to have a fallback option finance their own state exchange. But as I said before, under all 3 options, the only real thing the federal government should be involved in is making sure you're eligible based on your citizenship status and how much of a credit you should be getting. And I'm going to stop there so there is time for questions.
Hello, my name is Devon Herrick. I'm a health economist and I'm also a senior fellow with the National Center for Policy Analysis. My talk is more, I don't know, it's more theoretical, I guess, from the standpoint. I'm going to show you some examples that just everyday physicians can do to be more competitive. Every day, millions of Americans go shopping. In doing so, they compare the cost of groceries, clothing, cellular telephone service, you name it. Just something we do every day. We comparison shop. That activity stops whenever we turn to healthcare. I mean, 1/5 of our economy is spent on healthcare, but yet we don't compare prices. We don't ask these tough questions like, doctor, what does that cost? Well, what does that lead to? Well, as you can see by my slide, we have no competition in healthcare in the traditional sense. There's enormous waste because of that. Consumers and providers have very little incentive to control costs because third parties are paying about 89% of our bills. Next slide, please. Well, if you look at this slide, you can see that's our healthcare spending. It started out very low about 55 years ago, and as you can see, it is skyrocketing upwards to $5 trillion by 2023. Right now, it's right in the neighborhood of $3 trillion. If you look at the very, very bottom, the blue bars, that is what we pay out of pocket, about 10% of our healthcare spending. The problem with that is that is where the innovation comes from for the most part. That is the area where in other areas of our economy, physicians are other areas of our economy, stores, our providers would be, suppliers would be looking for a way of getting me to turn loose of my dollars. And that's where for example, a lot of innovative things like retail clinics formed outside of the third-party payment system. The reason is in telemedicine formed outside of the third-party payment system. And the reason is really should be obvious because health insurers are not on the lookout for new ways of spending their money. Whereas as consumers, you're always on the lookout for something that's more convenient, that's cheaper, that is has better quality or some amenity that you prefer. Next slide, please. So what does that cost us in terms of our healthcare system? Well, of course, we have, let's see here. As you can see, we are now spending a much larger percentage of our economy on healthcare, but also because we have no consumer engagement to speak of, healthcare is rising at about 3 times the rate of inflation. Healthcare prices are rising at 3 times the rate of all the other goods and services we consume. And healthcare spending is rising at twice the rate of our national income. Next slide, please. Well, that's true in most areas of healthcare. If you look at this slide, you'll see that over the last, I think it's 20 years, or a little bit over 20 years, our medical care inflation rate has gone up about 125%, whereas physician services have risen in price about 97%. The inflation rate, that's all other goods that you're consuming, your food, your car, your transportation, gasoline, you name it, have risen about 67%. Well, fix your eyes on the purple, I think it's purple bar at the bottom. That is an index of cosmetic surgery. It has risen only about 27%, actually lower than inflation. In real terms, real inflation-adjusted terms, it has gone up at rates about half inflation. So you say, well, why do we care about, Botox and skin resurfacing and other areas of cosmetic medicine? That's no one's going to die from the lack of a facelift. Well, the reason is because this is the only area of medicine, or just about the only area of medicine, where consumers routinely comparison shop, and physicians routinely offer package prices. They know they have to disclose the price to a patient, or the patient will go elsewhere. They know the patients are price sensitive, and one of the benefits of a price sensitive patient is the providers of those services, or the suppliers of those services, are on the lookout for a way of prying loose a dollar from that consumer. And next slide, please. So what's so different about cosmetic surgery? Well, among physicians, competition is fierce. Cosmetics physicians compete on price and quality. Cosmetic medicine is very innovative. Like I say, physicians are always on the lookout for a way of getting you to think you need their service. And now keep this in mind. It's the same physicians that oftentimes are operating in other areas of medicine. One part of their practice is bureaucratic medicine, where they might do OBGYN or other areas. And the other part of their practice, just to make a few extra dollars, is cosmetic services. Yet one area, they compete on price and quality, yet on the other area, it's a very bureaucratic system where nobody knows the price of anything. Well, so how does this affect patients? Well, if you look on the next slide, well, the reason is patients are price sensitive, and the doctors know that. Patients are decision makers. They're not asking for pre-authorization. They control their own funds. And by the way, demand is exploding. Now, can you imagine any other industry where, in the face of exploding demand and supply that's somewhat constrained, that prices wouldn't skyrocket? But yet, as you saw by my graph earlier, prices are very stable. Next graph, please. Okay, this is facelift surgery. Okay, granted, we don't all need a facelift. I mean, it's not something that's medically necessary. But look at the bars. About 20 years ago, the average surgeon fee for a facelift was just over $4,000. If you look last year, it was just over about $6,500. In inflation-adjusted terms, that is rising at right about the rate of our ordinary inflation, much below healthcare inflation. Why? Because these doctors are looking for any way they can to cut costs. They're doing OR in their offices, creating in-office operating rooms. They're offering package prices. I mean, these are entrepreneurs who are competing for the dollars of those people who they know are cost sensitive. Next slide, please. Well, if they're competing on cost, they're probably competing on quality, and they're also looking for ways, novel ways of attracting your business. The first bar is a facelift. The next bars that are all much lower, well, those are other methods to reduce the appearance of aging. They're much cheaper. I mean, ablative and non-ablative laser resurfacing, fractional resurfacing, chemical skin peels, microdermabrasion. These are all competitive products. These are all innovative ways of trying to get the guy who does not want a facelift to buy another product. Next slide, please. And again, this is just another example. And the reason why I have these examples is just to give you, these are all competing products. These are complementary products. These are all ways, very innovative ways of trying to get customers in the door, because in this particular industry, they have to convince patients that they want their services. And as you can see, these are injectables, like Botox is the first, and there are a whole range of products after that. Next slide, please. Think of all the areas of medicine and all the treatments you've ever thought of. If you look, go back. The reason why Botox is now a quarter of the market, so apparently it is very, very popular. In fact, one of the reasons why the cost of cosmetic services have been as low as they have for the last 20 years is because Botox is so prevalent and it's so competitive that it's actually skewing the index down. But look about 1999, 2000. Average price was around $365 for 20 units. It peaked about 500 maybe 7 or 8 years ago and fell back. It's now, I think, 370, 380 now. In every other area of medicine, this would be around 500 or above by now if it were any other area of medicine. But in an area of medicine where the doctor has to compete on price and quality, it's actually about what it was 20 years ago or 10 years ago. And in fact, next slide, please. In fact, if you go online, every day of the week I get something from Groupon or Living Social. Can you imagine? I mean, when's the last time you had a doctor send you an email, say, I will do a hip replacement for a great price or for half price? When's the last time you had a doctor send you, I'll do an appendectomy? Well, of course, that's ludicrous. Every day of the week I get something from some unknown doctor offering to provide me a service. Sight unseen, of course, if I don't qualify, they would reject me and then kick me out of the office. Every day of the week, a doctor or a lab or a medical facility sends me an offer to do a service for a price that's oftentimes half the going rate. Well, that's the only reason is because these doctors are competing for business because they have to compete for business. As you look at that, and I can't see. There's just all manner of things on that list. And as a matter of fact, if you look at Botox, in fact, oftentimes it's the going rate on Groupon is like $149. That's half the price of the national average that physicians are charging. Well, I'll try to speed this up just a little bit. Next slide, please. As you can see, this is another very popular surgical procedure. The price has risen at rates. It's only about 130% of what it was back in 1992. So surgical procedure, very popular. Demand is exploding, but yet the prices remain very, very low. But your next question, if you're like most audiences when I tell this story too, is, well, but that doesn't count. This is just aesthetics. This is just beauty. These are just cosmetic procedures. How about LASIK? If your eyes are involved, you're probably more concerned about what happens to your eyes. This is an example of competition on not just price, but also on quality. When corrective eye surgery, LASIK, came out, the average price was around $2,100. As you can see, competition drove that price down to the point that by 2002, it was around $1,600. Well, you see the other line above that. Well, some doctors figured out, hey, if we prove our quality is better, we can charge more. A Lexus costs more than a Honda usually. Well, and in fact, custom wavefront was better. They could almost guarantee 20/20 vision, and so that price began to climb while the traditional LASIK stayed very flat. Well, if you go to 2013, there are some doctors who still advertise the bladed LASIK, but now the custom wavefront with the laser flap is about the same price that the old traditional bladed LASIK was about 14 years ago. And in fact, in my longer presentation, I had a screen capture from a Groupon where a doctor in Manhattan was offering to do the old LASIK. And see, this is per eye. I had last year a doctor in Manhattan offer to do the traditional bladed LASIK, both eyes, for around $1,700. That's half the going rate because they are very, very competitive. Okay, now let's get to something that's, for our purposes, more important. I mean, the whole point of talking about cosmetic surgery is just to show there are doctors out there that do curative medicine that's very bureaucratic, and they also dabble in cosmetic medicine where they're very competitive. Here is hip replacements, knee replacements. We do about 1 million of those per year, and they're increasing because they keep people out of wheelchairs. There's 78 million baby boomers heading toward retirement. Next slide, please. Well, as Ralph can tell you, that the price varies all over the map. There was an article about this in the New York Times, I think it was last year. A lot of hospitals, they can charge more than $65,000. That might be maybe a median price, possibly. Medicare might pay $12,000, $13,000 for that service. An insurer might pay $36,000 for a hip or a knee replacement. Well, the CalPERS system, the California Public Employee System in California, collaborating with WellPoint, or now Anthem at the time, figured out that there didn't seem to be a difference between the surgeries that cost $100,000 and those that cost $30,000. The $100,000 surgeries did not seem to be any better. There's no real correlation, so they did an experiment. It's called reference pricing, and this is a way to harness consumerism and inject it and insert it within our third-party payment system. So what they did was they communicated with the enrollees, with the doctors, with the hospitals, and said, okay, our enrollees can go, our beneficiaries can go really anywhere they want to go. But if they go to a hospital that charges more than $30,000 for this procedure, they're going to be exposed to their usual cost sharing, but also exposed to 100% cost sharing for everything above $30,000. And they were very good about communicating this with the doctors, the patients, as well as the hospitals. Within a year, most of the patients had switched over to one of the, 46 hospitals that would perform this surgery for this price. Within 2 years, a lot of the high-cost hospitals had begun matching that price. And so it can be done not just in things that don't matter, like cosmetic surgery, or things that really do matter, like LASIK or corrective eye surgery. It can also be used to lower cost in some of the areas of medicine that are more standardized, like hips and knee replacements. Let's see, the next slide. Now this is an example of just the implant device. The list price of the prosthesis, the actual implant that you might use in hip replacement, oftentimes they can be all over the map. I mean, I have found the price $13,000 to be a pretty common figure. I talked to Blue Cross of Texas, and their actuaries told me that they were hesitant to even give me a range. It was so variable. The hospital might pay $4,500 to $7,500. In the U.S., the marginal cost to manufacture something like that could be $350. Abroad, it could be $150. And so, as you can see, there's a lot of room for competition. There's a lot of area to have doctors compete on price, to use reference pricing, or in Ralph's case, to use doctors who bid for procedures. Next slide. And oddly enough, as I was on the plane, I changed my conclusion, but he'd already had the old version, but I'll tell you what it is. The market for cosmetic surgery shows that physicians can be very competitive. Oftentimes it's the same physicians. Marketplaces where patients are paying cash, or at least are having significant cost sharing at the margin, function like normal, healthy marketplaces. In the case of cosmetic surgery, the prices for those items that must be done by a surgeon have risen at about the same rate as the inflation rate for all other goods, compared to medical care, which has risen at 3 times that rate. And oddly enough, the services that can be done can be farmed out, like Botox or laser resurfacing, things like that a doctor can train someone in his or her office to do. Well, supply can expand, substantially, and for those procedures, those have gone up in price at rates far below inflation. But what I'm trying to impart with you today is not how great cosmetic surgery is, just how great competition is. And if doctors can do this in one area, they can do it in the other area. We just have to give them the right incentives to do it that way. With that, we will entertain any questions you may have.
So you spoke about your support for the competitive bidding program, and I get a lot of health professionals that I meet with that are really, they have a lot of problems with like the non-binding bids, where bidders don't honor their bids and totally lowball them, and then we'll take those contracts and sell them at a profit. So I'd just be curious to see what your perspective is on that. And then for the rest of you, I don't know if you're familiar with the story that broke this week about the co-ops that were established by the ACA, but CMS was helping set the premiums for those. Well, there's 2 in the black, 21 in the red, and they're kind of finding out that it was semi-politically motivated, and you're all in support of competition. I'd be curious to see what your perspective is on that.
In regards to the bids that are placed on MediBid, they're binding, barring complications. In some things that are a little bit more complex, first of all, when you go online to make a request for, let's say, a hip replacement, you put down your height, your weight, your age, your gender. You answer about 8 health questions. Do you have any allergies to medications? Are you hypertensive? Blood pressure, et cetera, et cetera. Now, if you've sort of misrepresented something, and if you said, I'm 125 pounds when you're actually 325, it's a totally, all bets are off, because it's a much more complex procedure. The doctor, and you can upload documents as well, an x-ray, an MRI, physician's notes. So the doctor, when they make, and it's actually doctors making the bid, it's not the front office people. They actually review the files, and they'll say, this is a low-risk patient, so therefore we can do it at an outpatient facility, therefore it's going to be this. And sometimes they will put a range. Sometimes they'll say, it's probably going to be about 12,000, but it could go as high as 15 if I find, XYZ.
Are you familiar with the co-ops?
Yeah, my only comment about the co-ops would be that I think that was probably pretty predictable. I think the examples that Larry gave in his presentation about CMS policy and how it really doesn't jibe with real market and real life experience is simply the function of central planning. And when you try to centrally plan healthcare and who's going to get what service and at what price, it rarely goes well. And rarely do you estimate the costs accurately. And the actuaries that CMS worked with probably did as good a job as they could. Maybe there was some tinkering along the edges for political reasons, but they probably gave as good estimates as they could. They're just not in this business. That's not what they do for a living. And so health insurance, for-profit health insurance companies, tend not to underestimate these things and tend to price their products and their premiums in a way that they think are sustainable. And it's experience that they've gained over the years. So it's not a shocker to me that CMS tried its hand at it and it didn't work out so well.
And may I just add real quick, you have to ask yourself, so why did almost every single government-sponsored, I'm sorry, what are they called? Sorry, when the government comes in and gives a grant to typically a PHO, physician hospital organization, and they ask that PHO to try to save money in some way, why do they all fail? Right? Because the government is establishing the criteria instead of the private sector. And yes, they talk to the private sector about it, but then they make their own decision. And secondly, the government is actually handing money, free money, to the private sector for the demonstration projects. Sorry, that's what I was trying to say. So you look at all the demonstration projects, they've all failed, right? Why? Because the government is just handing money in the form of a grant with some strings attached, but they don't really even know how to design the strings. So they failed because the private sector, when the private sector has competition built in, then, as John just said, the health plans will design pricing, premium pricing and so forth, to be sustainable, but they also will design it to try to overcome the competition. And when everyone is doing that in an industry, then you get the best pricing that is as low as possible for the consumer and the employer, but sustainable, right? That's what private sector competition does. And when our government finally realizes that their role is to empower the private sector and regulate it so that you regulate out abuse, because abuse occurs in the private sector too. So you have to regulate to make sure there's no abuse. In the Medicare Advantage system, it's damn near perfect. Why? Because the regulations that have been promulgated over 10 years are regulations that benefit the seniors, the Medicare beneficiaries. The regulations are designed to make sure that the private sector does not abuse the seniors. So it works. I want you to think about something real quick, and I'll let other questions occur. Why was Medicare Advantage, when President Obama took office in 2009, the market penetration of Medicare Advantage was 22%. Mm-hmm. And if you recall, he and the CMS took 15% away from the top line revenue for these health plans. And that 15% has been taken away it's a 7-year period. It's almost all gone. That's 15% off the top line that the HMOs have received to do Medicare Advantage. That 15% never went to executive salaries or to shareholders. It went to pay for the increased benefits that the HMO is forced to provide to be a Medicare Advantage licensed provider. That 15%, it just made me crazy to hear CMS and the president talk about this 15% that was just going into the pockets of the executives. That's never happened, I promise you. It only pays for the increased benefits and the lower out-of-pocket cost that these beneficiaries receive when they go in Medicare Advantage. So again, the government basically is trying to put the private sector under by taking 15% off the top line. So what has happened though? Despite that fact, Medicare Advantage now is almost 32% market penetration. Why? Because there's so much competition. And because beneficiaries love it. You can't find a beneficiary that once they've picked a Medicare Advantage plan that leave Medicare Advantage. They might change HMOs, they might change health plans, or they might change PCPs, but they almost never leave Medicare Advantage because it's a wonderful thing. Sorry. Yeah, I went beyond.
Good answer, anyway.
A question and a comment. So I think the point about dynamic pricing is an interesting one. But as somebody who, as a consumer, has chafed against paying a high price for a hotel room at the last minute because I had to go somewhere, I wonder what the downsides might be for medicine, where you can't always plan your medical event. And then I have to say about the cosmetic surgery, it's not a fair comparison. That's an entirely discretionary category. Those are people who don't have to have those procedures. If you are somebody who's diagnosed with pancreatic cancer, you're not going to get a Groupon coupon for a Whipple, okay? I mean, so I think it works perfectly when people have entire choice about things and have the resources, but I don't see how it really works for somebody who doesn't have resources. They should still have an option, they should have choice, there should be transparency, but I don't think it's quite as simple as that analogy makes it sound.
I'll start with your first comment. Obviously, it's not practical, it's not even possible to request a bid in the ambulance on the way to emergency. A reporter on
You wouldn't want that
asked me
business.
about that once.
That's
You
great.
know, our app just isn't that fast. But many of our facilities have a buy it now price, and that price is based on anybody for this procedure, and it's usually higher than when they bid, but they say this is our cash price for prompt payment. Okay, pay me at the time of service, pay me in full, this is what I'll accept, okay? And then if you say, well, that's fine with me, then bang, click, buy now, just like when you go on eBay. A lot of people do that instead of waiting 7 days to see, those that do want maybe a little bit more competitive pricing because they're a low-risk patient or they want to shop around for other procedures, they can still engage in the bidding. Does that answer your question?
Yeah, I would hate for hospitals to be charging more because they've only got 3 beds left, where they just went off of alert and get the ICU bed now while you can.
Well, I think the buy it now price is based on optimal, occupancy, but then when they have empty beds, well, you know what, we can take a few dollars off, just like flying standby. When you fly standby,
But you wouldn't want to do that for a bypass surgery, right?
No.
Why?
Well,
Standby.
Cosmetic surgery, you don't want to.
Actually, we did, I'm sorry, sorry, Devon, we did have a patient from Canada that had triple bypass surgery for $14,000 in Oklahoma a few years ago, when the charge master price is $143,000. So,
Well, there's medical tourism where people,
Sure,
when
yeah.
these are somewhat elective procedures, but
Right.
if it's an urgent thing,
yeah, oh, sure, obviously.
Now, I will say also, what is happening now is, and this is actually happening because of the ACO legislation in the ACA. What's happened is more independent practice associations, IPAs, or call them group of managed doctors, a network of managed doctors, they have been formed, right, to deal with the accountable care organization beast, right? So what is happening now is these IPAs are preparing for a risk-sharing environment on the ACO side. And many of them have done risk sharing on the Medicare Advantage side for years, so they're quite good already. And they are now getting involved in getting hospital pricing, procedure pricing, imaging and surgery center pricing on an outpatient basis much lower. So it's not the consumer doing it, but it's these groups of physicians doing it on behalf of the consumer and on behalf of their ability to make bonuses. I mean, Ralph pointed out correctly that Medicare pricing is very low. I mean, it's very low. It's the same or lower than most of the MediBid pricing that they get on an average. So that tells you what we all know. Primary care physicians especially are just paid at ridiculous low rates for their Medicare patients. I mean, it's just ridiculous. And so, and at Integranet, we require them to spend more time with their Medicare patients. So when they meet our P for Qs, our doctors get a lot more money than Medicare rate. And we change their behavior with money. That's the beauty in the private sector. So.
Oh, well, I was going to say, to your point about cosmetic surgery, that's why I include the LASIK procedure, and even the hip replacement is some things, as Ralph said, you're not going to Google the cheapest hospital while in the ambulance, but a lot of our, a substantial majority of our healthcare is not spent on people who encounter our healthcare system from the back of an ambulance. And if you could get doctors and patients, even at the margin, like the hip replacement, that was an example of being price sensitive at the margin. If you could get doctors and patients to be, more competitive, even if the margin, if they have health insurance, their behavior would change over time, and you wouldn't really have to worry about every single time you need something done, the price being $100,000 list, negotiated down to $35,000. Well, $100,000 is not a real price. No one would ever pay that. So we just need to increase competition. We don't necessarily have to get 10 bids from 10 different doctors to see which one is the cheapest for all things, but if we can get a environment where physicians know that cost is an issue and patients know that cost is an issue, and some of the easiest way is low tech. It's asking the doctor, do I really need that MRI? Or how much is that MRI going to cost? The doctor can't answer it, but the fact you ask that question prodded a thought in their head that maybe I should find out the average price of an MRI so I can advise my patients.
An interesting comment that I'd like to add to that. Often when a patient requests, for example, a knee replacement, the doctor will go online and they will review the patient history and they'll say, I'm not entirely sure that you need a knee replacement. You might consider knee arthroscopy, for example, or some other alternatives. Now, there are some alternatives because we have providers in 10 different countries that aren't FDA approved, such as high-intensity focused ultrasound for cancer, prostate cancer, hyperthermia for breast cancer, things like that. There are some stem cell therapies that regenerate knee, cartilage and stuff. So there are some things that aren't FDA approved in the U.S. that can be done, often offshore, Costa Rica, Mexico, Thailand, et cetera. And sometimes they will reply and they'll say, yeah, I could do a knee for, $13,000, but you might try this first.
Okay, so to follow up on the FDA issue, there's a lot of things that seem to be almost here in terms of non-invasive diagnostic devices, but the FDA is regulating software and non-invasive diagnostic devices as if they were medical devices properly. So I was wondering if you all have any thoughts about how that might be retarding kind of not self-diagnosis, but individuals using these tools that use complex algorithms and the best data out there to see what might be wrong with them.
Well, I think that there are a lot of devices that attach to phones, for example, blood pressure, heart rate, pedometers and stuff like that, which are good measurement tools, but by themselves, it is hard to diagnose, and you don't want to do that. I mean, that's like, I saw this commercial a couple of years ago, I forget what it was, about somebody performing surgery on themselves, watching YouTube, cutting their belly open or something like that. There will be people, even now people self-diagnose themselves. They'll read, symptoms at WebMD and oh yeah, I got that, type of thing. So you're never going to completely eliminate it, but I think these tools are good for to use in conjunction with telehealth, for example, where you can call in your doctor and say, hey, listen, I've just uploaded my tests into Dropbox. Can you check them out and go over it with me?
Integranet is looking very seriously into smartphone applications, that just sit on your smartphone, that would help us monitor diabetics, as an example, at home. So we're looking at those tools. We've already implemented a HIPAA-compliant communication tool. That's an application that sits on the smartphone, and we've actually mandated that across all of our providers, and that's really improving care coordination because it's improving communication between all the providers about a patient. So it's a big, big deal. You can save a lot of money just by improving communication across all the providers.
Do you find the FDA is impeding the development of that at all?
This is not under the realm of FDA. This particular, a communication device, but yes, it impedes the development of like diabetic monitoring. It does, yeah. But there's pros and cons and all that. But yes, I just find in general that the regulatory bodies have become much more militant. It seems like across the stage, last 5-6 years. So.
That's the final word. Thank you again to our panel, and if you have any questions, feel free to get the contact information and our contact information and NCK's in the packet. So thank you again for coming.